A very good morning to all the students. I hope you are all safe and staying at home. So today's class will be learning about cleft lip and palate. I am Dr. Shyamala from Department of Orthodontics. So in today's class, you will be learning about how to identify a cleft lip and palate, the different classifications involved with it, and how to formulate a treatment plan or how to manage a child with cleft lip and palate. Okay. Now, as you all know, what is a cleft? The word itself says that a cleft is any deformity, okay, or discontinuity. Yes, so if there are two things and they are, there is a discontinuity when you join them, it's called as a cleft. So a cleft involving lip and palate are most commonly seen congenital abnormalities in orofacial region. Yeah, so they can occur individually or they can be in combination with some other syndromes. Yes, okay. So they can occur usually you get to know whether the child is having a cleft lip or palate in the womb of the mother itself. Yes, so we will be learning more about that later. Now, it is found to be different among different races. Negroids have the least incidence according to few reports, and Mongoloids have the highest incidence. Now, they say that cleft lip is common mostly among males, while cleft palate is more common among females. But of course, there are many studies contradicting to this also. Yes, so just know for now that cleft lip and palate is the most common congenital abnormality. Yeah, unilateral cleft you will see around 80% of incidence, and bilateral about 20%. Now, when we are saying cleft lip and palate, it is important to know what went wrong in the embryology. Yes, so all of you have studied embryology in your first year. So all of you know how the face is formed. Yes, it is formed by the fusion of a number of embryonic processes, okay, that form around the stomodium, which is also called as the primitive oral cavity. Now, around fourth week of intrauterine life, okay, you all know branchial arches and the pouches develop, right, which gives rise to various processes such as the maxillary process, mandibular process, frontonasal process. Okay, the fusion of few of all these processes forms the face, and subsequently your palate, your mouth, yes, and your tongue, all those things. So to be more specific to this lecture, the palate is formed by the contribution of your maxillary process and your frontonasal process. And the union of the two palatal shelves from your maxillary process, okay, is initially prevented by the tongue. But as and when the child or the fetus grows, okay, the tongue descends down to the floor of the mouth and the two palatal shelves, they tend to fuse, right? That happens around seventh week of intrauterine life. Now, by around 8.5 weeks, the two shelves are in close approximation, okay? So the palate is formed basically by the fusion of the maxillary shelves with each other and with the frontonasal shelves. Now, when we are talking about it, it's very important to know the etiology of cleft lip and palate. That means what is the cause that leads to this problem, right? So there are various genetic and environmental factors. The most common ones are heredity, environment, and multifactorial. We will go in detail about it. Now, when we say heredity, Drilling reported that 1 in 3 children with clefts had some family members or relatives associated with such defects, right? Clefts of lip and palate can be transmitted as a dominant or a recessive trait. Genetic studies have revealed that family history is very important when you treat a case. Yes, so if there is a person or a family member having a cleft, you can expect 90 to 95% of the case to be the child to be having the syndrome. Now, when we say environmental, you must know that there are certain drugs or teratogens, okay, that are contraindicated during pregnancy, and it has to be avoided given to the pregnant mother. Okay, so some of these teratogens are rubella virus. Okay, so that can be one reason. If the mother has got the virus, yes, it is definitely going to the fetus, and hence it can be one of the cause or etiology for cleft lip and palate. Next is a drug called cortisone, okay, and mercaptopurine, methotrexate, Valium, and dilantin. All these drugs are contraindicated during pregnancy. Yes, and few infections like rubella, toxoplasmosis, which is spread by the cat feces, and syphilis have all been associated with cleft formation in infants of the infected mother. Okay, now there are a number of factors, okay, that are believed to increase the risk of the cleft lip and palate. Few of them are increased maternal age, racial, as I said previously, and lack of blood supply to the region. Now, how do you diagnose a patient or a child or the fetus with a cleft lip and palate? Now the times have far improved, and there are so many advances in ultrasound that it is easier when you go for your screening or monitoring during your pregnancy, the monthly checkups. It is very easy for the gynec to know if there is any situation that they see like cleft lip and palate in the womb, right? So ultrasonography and 3D sonography enables to diagnose much easier to diagnose a patient with cleft lip and palate. Okay. Now, why is it important to diagnose before itself during the baby when the fetus is in the womb itself? Why is it very important? First of all, it gives time for the parent to educate themselves, or for you to educate the parents prior itself on how the journey is going to be. And believe me, it's not going to be easy, right? So it gives enough time for the parents to understand the situation and to um, see what is going to be in forward of them in the future, right? And it allows psychologically to prepare them to for the what they have to expect in the future. And also when you do early diagnosis, it's important because it helps to detect other abnormalities if there, right? And of course it gives a parent chance whether they want to continue the pregnancy or not. Okay, so moving on, how to classify cleft lip and palate. Now there are few classifications. I have put only the important ones that you need to know, right? So Davies and Ritchie's classification. So what is all this classification is about is that they have grouped the patients according to their clefts of the lip or palate into few groups, so that it's easier for the doctor to diagnose, okay, and formulate a treatment plan, right? So now Davies and Ritchie's classification, they divided the groups into 1, 2, and 3. One is pre-alveolar clefts. Okay, these are the clefts involving only the lip, right? So they can be unilateral, bilateral, or a cleft in the middle. Group 2 are post-alveolar clefts. Okay, so it comprises of different degrees of hard and soft palate clefts that extend up to your alveolar ridge, right? And group 3 are alveolar clefts, that is, they are complete clefts involving the palate, the alveolar ridge, and the lip. And again, they are subdivided into unilateral, bilateral, or medial. Next is View's classification. He divided the groups into group 1, clefts involving only the soft palate; group 2, clefts of hard palate and soft palate extending up to the incisive foramen; group 3, complete unilateral clefts involving the hard palate, soft palate, lip, and alveolar ridge; and group 4, complete bilateral clefts affecting the soft palate, hard palate, lip, and the alveolar ridge. Moving on, there is a classification by Fogg and Anderson which was given in the year 1942. So they divided again into group 1, group 2, group 3. So group 1, they are clefts of the lip. It can be divided again into unilateral or bilateral. Group 2, they are clefts of the lip and the palate, and again they are divided into unilateral and bilateral. And whereas group 3, they are clefts of the palate extending up to your incisive foramen. Now, Schuchard and Pfeiffer's classification, right? So they divided into this chart, okay? So this chart as you see here. So lip, alveolus, and hard palate, and this is the soft palate, right? So if the patient comes to you and says, you know, it has a unilateral cleft lip, so you can just, tick here. If they say the cleft involves your right, of the lip and the alveolus, so you take this one over here and this. If it involves all the hard palates also, here. And if it is involving lip, alveolus, hard and soft palate of one side, here. If bilateral, then you take this side also. Okay. Okay. Now, Carnahan's strip-wide classification, as you can see, is something like this. Okay. Yes. So this here is your incisive foramen. Okay. Behind this, you have your soft palate, and this is your right and left side of your hard palate, right? Larshall's classification. Yes. So Larshall gave a classification. Okay. It was given by O'Crians in the year 1987. So it involves the term, right? Lahshal. Okay. That means lip, alveolus, hard palate, soft palate, and alveolus and the lip. Okay. So right and left side, it has been divided into like that. Now, when they say that LNS, it stands for cleft of right lip and soft palate. Yes, so vice versa. Now, what are the problems associated with clefts, right? What do you mostly see in a patient with cleft lip and palate? Now, there are a number of problems that you can see. They are broadly classified as dental, aesthetic, speech and hearing, and psychologic. Now, understand that this is your short answers and can be your MEQs, essay questions also. Okay, so carefully listen to this one. Now, what problems do you see under dental? Now, you can see a variety of problems here, right? So it is dependent upon, how the cleft have divided, how much it has displaced, where is the deficiency, okay, and how much it is deficient, okay. So you can see congenitally missing tooth, which is most common that you see in a patient with cleft lip and palate. Yes. Then you see presence of natal and neonatal teeth. You see presence of supernumerary teeth. You see a lot of ectopically erupting teeth. Enamel hypoplasia, microdontia. Yes. Tendency to mostly present as a class 3 skeletal pattern. Protruding premaxilla. Because of the lack of the fusion, the front of your maxilla tends to be protruded out. Deep bite, gemination, dilaceration, which are more common. Okay. As you can see in this picture, a patient with cleft lip and palate, you can see the cleft over here. Yes. So you see a lot of missing teeth. You see a tendency of a class 3. Yes. So inside you see some impacted teeth, some rotations, some malocclusions. Yeah. Aesthetically, definitely there is a problem, right? It can lead to facial disfigurement. Yes, oral facial structures may be malformed and congenitally missing. And sometimes, if it is an extreme case, you also see a deformities of nose. Hearing and speech is affected definitely. Cleft lip and palate are associated with disorders of middle ear infections, okay, that may affect the hearing. This can cause difficulty in language uptake and speech. Nasal resonance, palatal dysfunction, and midfacial hypoplasia all contribute to speech difficulties. Prosthetic aids are hence available to help in speech. Now, moving on, how do you manage a patient with cleft lip and palate? Yes, so as you just now saw, there are complexities of problems, right? So many of things are that it has to be addressed in a patient with cleft lip and palate. So it is not only an orthodontist job or a prosthodontist job or a pediodontist job. Yes, it is an multidisciplinary approach that has to be given. Yes, so everybody has to play a part, okay, in treating a patient, right? So that's why it's important to diagnose, okay, before itself. The early the diagnosis, it gives ample amount of time for the doctor to plan out, right? So what all we need to do, um, eh, you know um, which all departments have to help you out in treating this patient. Yes, okay. Now, when I say management, okay, there are stages on how do you manage a patient, right? You cannot, as soon as the baby is born, okay, you cannot just immediately go and do a surgery, right? So stage by stage, okay, when you have to treat, okay, and when they will be okay to undergo a surgery has to be planned out. Yes, so stage one, this comprises of treatment that you do from birth to 18 months of age, right? Stage 2, this is from the 18 month to 5 years of life, which usually involves primary dentition. Stage 3, it includes the treatment carried out during the mixed dentition stage, okay, that is from 6 years to 11 years of life. Stage 4 includes the treatment done during the permanent dentition stage, that is from 12 to 18 years. Okay, so what happens in stage 1 treatment? Yes, anybody? Okay, the treatment modalities in the first stage are fabrication of passive obturator. Can anybody tell me what is a passive obturator? Can anybody think of it? Okay, so I hope you all could recall, okay, what is a passive obturator or have a image in your mind, right? Okay, so fabrication of passive obturator, I will be talking more about it. Pre-surgical orthopedics, surgical management of the cleft lip, followed by surgical management of cleft palate. Now, before we dive in into what is to the next part, let me explain to you what an passive obturator is. Yeah. Okay. Now, as soon as the baby is born, what do you think the first problem the mother will face? Okay, the difficulty that the mother will face. Yeah. Yes, feeding the child. Yes, so it becomes very difficult for the mother to feed a baby with a cleft lip and palate. Of course, the baby will have even more difficulty because there is a discontinuity, okay, in your palate, right? So the suction that we get from sucking the nipple, the milk that flows through the mouth goes through the nose. Yes, you can imagine how painful that can be for the baby. Yes, so what we do is we fabricate something as an obturator, okay, it is actually like an acrylic plate, okay, that we put in the palate. Yes, so that helps to close, okay, the cover the palate so that the baby can have the suction or the grip to drink the milk, right? Basically, that is the design of it. We will more detail about that. Okay, so this here, do you see here? Okay, this is called as the obturator. Yes, so you see how it is made of basically acrylic. So what we do is when the baby is born, yes, so you take an impression of the mouth with an alginate impression, right? You take an impression of this mouth. You can imagine how difficult it would be. Yes, taking impression of the adults is, you know how difficult it can be with the gagging, and also imagine a tiny baby. Yes, so you have to take the impression of the mouth with the alginate and then pour the cast. Once you pour, you have to make an acrylic plate, something like this, right? You can see. Yes, so basically it is an intraoral prosthetic device that fills the cleft of the palate, thus providing a false roofing kind of thing against, the suckling of the child. It thus reduces the feeding difficulties, okay, such as insufficient suction, excessive air intake, and choking. It provides maxillary cross arch stability, preventing the arch from collapsing. Okay, so it also helps in stabilizing the arch. Okay, it holds what is, there. Okay, so that it doesn't worsen in the future. Now, this is something that we don't do now, but you have to understand. Okay, this is done very, very rarely. Pre-surgical orthopedics. Basically, the aim is to achieve an upper arch form, okay, that conforms to the lower arch. Okay, the orthodontist should try to correct the displacement, usually by taping or strapping across the premaxilla attached directly to the face. Okay, so what helps is, as you can see in the picture, if you strap like this, yes, if you strap the maxilla, it stops the maxilla from further growing. Okay, especially when you have a premaxilla hanging up, right? So that it restricts the growth of the maxilla and it can be in par with your mandible. Yes, usually what they use is a micropore adhesive tape. Yes. Now, what is the advantage of this? It reduces the size of the cleft, thereby aiding in surgery. Partial obturation of the cleft assists feeding, and there is an improved speech as because the size is reduced. Now, surgical lid closure. Yes. So, when do you attempt for the surgery? Yes. So, some prefer to say that surgery should be done soon after birth, while others recommend a late lip surgery. Now, early school suggests that surgery should be performed within the 45 days of birth. Yes? Okay. Now, the most important thing you must know here, which is your 2 mark question, your MCQ question also, or can be a part of your short answers or MEQs, Millard's rule of 10. Right? So, Millard was a person who suggested the rule of 10 when you see a baby with a cleft lip and palate. He says that surgery of any kind should not be performed less than 10 weeks of age, the body weight should not be less than 10 pounds, and blood hemoglobin should not be 10 grams of HP, right? So, and surgical palate closure. The palate repair should not be attempted at 12 to 24 months of age. Okay. And what are the bones that can be utilized for the transplant? From your rib, iliac, and your symphysis of your mandible. Now, stage 2 treatment is obviously as the baby is growing, you need to adjust your obturator to maintain or check the eruption pattern and timing, restoration of your decayed teeth, right? Because the patient is already in the primary dentition stage, and your mixed dentition in some cases. Stage 3 treatment is correction of your anterior cross bites, buccal cross bites. Okay, usually you give your expansion screws, okay, to allow the permanent to erupt, to give the space, right? If you see an arch constriction over there. Stage 4, the patient is definitely now an adult, so you definitely a fixed orthodontic treatment is what is required to correct all the local irregularities like your crowding, spacing, crossbite, okay, overjet. And of course, if the patient is still in your mixed dentition stage, okay, then you can obviously, or a growing stage. Now, I assume all of you know how the growth or the skeletal maturity indicators, right, on how to know whether the patient is growing or not. Yeah, so when you see that the patient is still in the um, there is still some amount of growth left. Okay, so you can use some growth modification appliances like your face mask and your headgear, reversible headgear based on what the deficiency is. Yes, to avoid extensive surgery in the future. And of course, when you give a fixed appliance, a long-term retention is needed, okay, because there is an inadequate bone support there, there is an absence of some teeth, okay, there is scar tissue there, so you don't know which will contribute to relapse later. Okay, so this is a chart, okay, which says comprehensively what to do, okay, when the patient is at each stage. Okay, so that's all for today. Okay, so thank you everybody. I hope you understood the cleft lip and palate and how do you manage a patient with it. Any doubts, please post a comment on the e-portal. Okay, and if you have some queries about it, you can also post in your Google Classroom. Yes, I hope you all stay safe and stay indoors. Thank you.